when people think about kidney failure, they think about either the patient's going to get dialysis or the patient's going to get kidney transplant, which doesn't happen for everyone. So being able to assess symptoms and manage symptoms and talk to the patient and walk them through, show them that we are going to keep you as pain-free as possible. Pain is one of the really important symptoms that you need to make sure you assess properly and treat properly for as long as possible.
I think the best tool that you can use is silence, and ask the patient to tell their story of their pain. And with that, you will get most of your information.
Being able to provide palliative care for the patient saved my nephrology career. Otherwise, I would really be helpless. So I think it's a very significant part of kidney disease care, especially in resource-limited settings such as ours.
So we are asking across the world that we at least have access to morphine as an essential medication. And therefore, we need to look at morphine use in these patients. How are we going to use morphine in these patients safely? And again, the principle of starting low is there, but not say, do not use it.
I'm joined today by Dr. Peace Bagasha and Professor Renee Krause. Dr. Peace Bagasha is Clinical Head of Nephrology at Malago National Referral Hospital in Kampala, Uganda, and Nephrology Course Lead at Makerere University. She has contributed to expanding access to kidney care services in Uganda, playing a key role in establishing Uganda's first kidney transplant programme. She's currently pursuing a PhD examining quality of life in end-stage kidney disease, integrating palliative care principles into clinical practice. Professor Renee Krause is head of the Division of Interdisciplinary Palliative Care and Medicine in the Department of Family Medicine, Community and Emergency Care at the University of Cape Town. As a family physician with a PhD and a Master's in Palliative Medicine, she is convener of the Postgraduate Diploma in Palliative Medicine, working clinically at Groote Hospital in Cape Town. Professor Krause is a board member of the African Palliative Care Association and assistant editor of the Journal of Primary Health Care and Family Medicine.
It's really a great pleasure to come and talk about conservative kidney management. So my background is nephrology. I've been working, as soon as I finished my internal medicine, I worked with the palliative care unit for about 2-3 years before I specialized in nephrology. So I've always been interested in palliative care. It was really a great privilege to be able to integrate palliative care into kidney disease care. I think the reason why is because at the end of the day, most of the patients who we see who have end-stage kidney disease end up not being able to afford dialysis. So if you can't do dialysis for them, if you can't do transplant for them, what else can you do?
I think when palliative care started, it was really from a oncology point of view, but especially in South Africa and Sub-Saharan Africa, where we had the HIV pandemic. I work currently clinically in Groote Hospital in Cape Town, and it was really where we started seeing more and more end-stage kidney patients being referred to the palliative care system. And I must say, I must mention Frank Brennan, who wrote all the wonderful work on renal failure and who actually came to visit us in the unit, who sort of highlighted all the things that we can do for patients with chronic kidney disease. I also think that the place why it's always so hard to look after these patients, and perhaps I'm running ahead of myself, is the amount of anger that's associated with chronic kidney disease. Where patients in South Africa, in the public healthcare sector, we've got choice-restricted dialysis, so not all patients would receive dialysis. And there is usually an underlying anger regarding that. And that's why these patients really stand out to you, because you are always managing a complex family situation.
So from the paper, we basically thought that if you sum them up, there'll be 3 groups of patients who will need conservative kidney management. So the first group is patients who say they don't want to have dialysis at all. And these will be patients who have maybe had an experience with dialysis. Maybe their brother was on dialysis, so their sister was on dialysis, and they didn't really have a good time. And they decide, I don't want to do this. So that's the first group of patients you will have. And then the second group of patients is patients who will be too frail for dialysis. So say, for example, they have really bad heart failure and they're not able to sustain dialysis in terms of their physical well-being. And then the last group, which is the most common group, is the patients who are unable to afford dialysis due to a variety of reasons. So say, for example, they can't pay the out-of-pocket costs, or they don't have the insurance to be able to do dialysis, or they stay very far away from a place that has dialysis. So, for example, if you consider a country like mine, like Uganda, we only have dialysis in about 3 or 4 districts. And then patients who stay so far away from those districts, even though they're able to afford to pay for dialysis, the non-dialysis related costs is actually what will throw them out, and they'll not be able to sustain dialysis. Those extra costs mean they're not able to pay, even if they're able to pay for the dialysis itself. And because of that, it means that in our setting, because of the resource limitations, we will have both the old and the young. So you have like a 23-year-old who has end-stage kidney disease and cannot afford to pay for dialysis, and they're otherwise strong, healthy people, and they can't afford to pay for dialysis. So that's the group we call the choice-restricted patients. So if you can't offer dialysis or kidney transplant with them, then at least you can offer conservative kidney management as an option of care for them, so that you don't feel like you're doing nothing for the patients.
Renee, did you want to say anything about the choices in your setting? Is it fairly similar to the situation that Peace described from Uganda?
So in South Africa, we've got 2 healthcare systems. We've got the private healthcare system where anybody can have dialysis if you can afford it. But in the public sector, there in the Western Cape where I have, there's specific criteria that will sort of get you if you are able to be dialyzed or not. And I think firstly what we need to realize from our point of view is, and especially when we're talking about a primary healthcare system, many of the patients and the complex conversations actually happen in primary healthcare settings. Many patients will not even come and see a nephrologist. So those patients who see a nephrologist are actually some of the fortunate patients in our settings. And then only can the conversations about dialysis start. And as we know, as you stated earlier, many of these patients are relatively young, about 55, 60-year-old patients. And they will have dependents still. They will still be working. And they would be quite angry at this debility that they have at that stage.
So the other group of patients that you highlighted in the paper were drug users specifically.
In Cape Town, we do have a drug problem, and we have a definite problem with meth. We call it takia on the Cape Flats, and it is a drug that also causes a lot of aggression. These patients need to demonstrate that they have been rehabilitated to actually then access a renal replacement program. So it is difficult. So that, and I think it's important to ensure that we mention contextual issues when we are talking about renal replacement. It's not a quick treatment. It's a huge, complex intervention. And for me, the pain that goes around with it, the family pain that goes around with it, and the labeling of at different healthcare sectors, and that patient then seeking help becomes also very complex because there is stigma attached to those patients.
If we move on a little bit to the kind of general approach to pain management.
So in terms of pain management, we know that most of the patients have multidimensional pain when you assess your patient. And assessing patients for multidimensional pain usually involves looking at the psychological aspects of pain, the physical aspects of pain, the spiritual aspects of pain, and not just looking at the physical pain. So most of the patients will have multidimensional components to their pain. So just like Renee had just talked about, they may have back pain, but probably it's made worse by the anxiety that they have, that they're not able to afford dialysis. So impeccable assessment of pain is really important, and thinking about it in that multidimensional aspect. We quoted a few studies in the paper where we talked about close to 60% of patients with end-stage kidney disease having pain, just pain, and more than 40% of these patients having really severe pain. So pain is very common and is often the problem that the patients will present with when they come, if you look at all the different symptoms that the patients will have. And the pain may be because of one physical illness. Say, for example, they have a diabetes and they have a diabetic foot, or it might be multiple illnesses. For example, they may have diabetes, but maybe they're older, they have arthritis as well. So there might be multiple causes of the pain, and you'll not be able to care for this pain fully if you do not assess it extensively. So the assessment of the pain is really a big part of treating or managing the pain. The psychological component of the pain sometimes will be cured just by you listening to the patient telling you about their pain, and they already feel like the pain has gone just because they talked about it with you. So having that broad perspective of pain is really important when you think about pain for this particular group of patients.
In the baby, you mentioned some of the assessment tools, the brief pain inventory and McGill pain questionnaire. Do either of you routinely use those in practice?
I don't know what you tend to use, but for us, we tend to, for me personally, or my team tends to use the pain scale, the 1 to 10 pain scale. So it's really easy to use. Every time you see the patient, you'd ask them on a scale of 1 to 10 how bad. Maybe I'm at a 10 today, or I'm at a 12 today. It's really, really excruciating. Or I'm at a 1, so that you're able to titrate your pain medication. So that's really easy to use in the routine clinical setting. Renee, I don't know if you're using the more complex tools, the McGill tool and the...
I use the tool called Silence, Jane. I keep quiet. Africans are storytellers. And I think the best tool that you can use is silence, and ask the patient to tell their story of their pain. And with that, you will get most of your information. The expression of pain is so complex, especially if nobody has spoken about their pain before. And I think the story of the pain becomes part of the therapy of the pain. So I would say the most complex tool you can use for pain assessment is silence.
So really, really useful lessons in terms of thinking about a general approach to pain assessment. And let's move on a little bit to neuropathic pain. Do either of you want to say anything about neuropathic pain in this setting, how it presents, any particular features that people should look for?
I think, Jane, it's the classic burning pain in the feet that we see. We see that quite a lot.
Right.
And I think because of the HIV and the diabetes, that is the common neuropathic pain that we see in these patients.
Then let's talk a little bit about adjuvants.
Yes. So in the paper, we talk about the most common adjuvants would be your gabapentinoids. So gabapentin, pregabalin, the tricyclic antidepressants, so amitriptyline and carbamazepine. Those will be the most common neuropathic agents that you will most likely come across. So in particular for renal patients, it's really important to start as low as possible because they will have a tendency to cause toxicity if you start at the usual bigger doses. And again, when it comes to renal patients, you have to think about what their glomerular filtration rate will be. So in this case, we're mainly talking about patients who have kidney failure. So that's a glomerular filtration rate of 15 and below. So I always tell patients that think about it as having 15% kidney function. That's what will be easy to think about. So if you have 15% kidney function and below, it means that your kidneys are not able to do for you the things that they would normally be able to. So if you have that low of a kidney function, then you have to think about the fact that the drugs might stay in the body a little bit longer than they should. And what that means is that a small dose may end up staying in the body for longer, and that means that it will accumulate if you take the dose repeatedly. So what we then would say is that you begin at the smallest dose possible. So for pregabalin, for example, we'll begin at 25 milligrams and then work our way up maybe every 2 to 7 days, depending on how the patient feels. And you'd be looking out for usually things like increased sleepiness, if they are getting more drowsy. Usually I will warn the patient before they start to take the drug that this is most likely to make you sleepy. So it's best to take it at night. And if during the day, the next day, you're still feeling extremely sleepy more than the usual, then it means that we need to taper down the dose a little bit. And part of the therapy, of course, for the pain is the counseling that you give the patient. So you have to counsel them and tell them you have to be patient. It will work, but you just have to give it time. Because if you increase it too rapidly, that usually will give you bad side effects, which you would like to avoid.
I think what you've said is two important things. Start very low, go very slow, and very importantly, educate your family members and your patient as you go. I think with all the drugs, those must be your core principles. Start very low, go very slow, and educate as you go.
So we'll use amitriptyline, but equally the same at a very tiny dose. So usually we begin with like 12.5 milligrams of amitriptyline because it's much more common. So we always tell the patients whatever you can get, you can use, but begin with the smallest dose possible.
So primary care, amitriptyline first, and then gabapentin if it's available, but starting at a low dose. With the proviso of those 3 points. Start low, go slow, and educate families as you go. It's a good mantra. If we talk now a little bit about non-opioids in kidney failure.
So in our settings, we would use Panado for mild pain. And I think with paracetamol, the big thing about paracetamol is people, if you are going to use it, please make sure the patient doesn't overdose on it. And the other thing, make sure the patient does actually take it regularly. And for moderate pain, we have access to tramadol, but very important with the tramadol not to go higher, not to higher doses with the tramadol, up to 75 milligrams BD with end-stage renal failure. And that's basically all that we have on our non-opioid. And you can sort of say a tramadol might have an element of opioids to it as well. So very few, I think, on our settings, paracetamol remains the only non-opioid that we have available as an analgesic.
And so the non-steroidals, which you write about in the paper, basically you're saying don't use them.
don't use them.
Don't
Yes.
use them. Yeah.
Because whatever we do, we mustn't do harm. So what we have kidney function left over, protect your kidney function that you do have.
So the most important thing is to preserve whatever residual renal function you have. So even if you have 5% renal function, you need to preserve it for as long as possible, because that helps you to reduce whatever little urine you're able to make is helpful, because it helps to reduce the symptoms. So we really want to preserve the renal function. So we explain to the patient that the big doses of NSAIDs are going to take away your kidney function. So if you must use the NSAIDs, you have to use the smallest possible and for the shortest time possible. You educating the patient is really important so that they know, and then so that when they really, really must, they know that they might be causing harm. And sometimes that actually helps the patient to avoid using it.
Yeah, and you make an important point there about the purpose of preserving kidney function at this point. It's not about numbers at this point. It's about the fact that residual kidney function can actually help to improve quality of life, because kidneys are still managing symptoms, aren't they, by clearing out waste products and so on. So it is still very important to avoid drugs that are going to cause any further damage to the kidneys if we're focused on quality of life, which obviously with these patients that's the priority and the goal, isn't it? So let's move on to opioids. In the paper you do outline, importantly, the challenges in access, of course, particularly to morphine, and some of the many barriers that there are in the countries where many people are requiring conservative kidney management, but may actually not have access to morphine at all for other reasons, for kind of regulatory reasons and so on.
The big thing is that we need to realize that is most probably the only drug that opioid or strong opioid that patients may have access to in the African setting, and especially, as you stated, where conservative kidney treatment is the most important. And I had the discussion with my first world colleagues that state that all the guidelines go to drugs that are more, or opioids that are more renally safe. And for 95% of Africans, that will not be available. Perhaps I mustn't say on the African setting, in any low middle income country, which is most of the population. So we are asking across the world that we at least have access to morphine. And therefore, we need to look at morphine use in these patients. How are we going to use morphine in these patients safely? And again, the principle of starting low is there, but not say do not use it. So morphine is not contraindicated, but it has to be used with caution. And how do we then educate our colleagues around that? And bringing out guidelines that say do not use morphine is not going to be helpful.
So in my setting, our starting dose for morphine is usually 2.5 milligrams. So the usual dose is 5 milligrams 4-hourly. So for the renal patients, we will start with 2.5 milligrams, and we will not use it 4-hourly, but we will use it 8-hourly. So we increase the interval in between the dosing, so that we give the body a chance to clear out the morphine, and then we will increase it by 2.5 milligrams every 48 to 72 hours, and also educate the patient about the possible side effects. So usually if they get really a lot of nausea, or if they're really drowsy, drowsiness usually, or sleepiness is usually the thing that will come up first. So that would be our usual starting regimen. And also we warn them about the constipation, because constipation is a known side effect. As long as you warn patients early enough and begin to prescribe a laxative early enough, that usually means that the patients won't hate the morphine, because otherwise the constipation can really make them hate the morphine.
We also have access to fentanyl, and we will provide fentanyl, but we will start also with extremely low dosages and observe and see how the patient responds. And it's really, especially at the end stage, we have to be very careful with the morphine, but also do not deny the patient morphine if they are in severe pain.
You mentioned hydromorphone, fentanyl, buprenorphine, and methadone. Do you want to, in terms of your expertise, comment on any of those apart from availability?
So Jane, I think from an African setting, we really need to start looking at methadone more. I think it's not an expensive drug. However, it is a drug that must be used with a lot of caution, and needs to be initiated, especially in our setting under supervision. But it's definitely not an expensive drug and might be an appropriate drug to use, especially if there's an element of neuropathic pain involved. But I would, if this is we need research on this, we need to talk about this more, and we need to get the papers out on using methadone for end-stage kidney failure before it will be approved. We have access to methadone in Cape Town, but it's only for people who are on rehabilitation. And I do think this is our biggest problem with fentanyl as well, that you can initiate it in a big treating center, but if the patient's going to a more rural setting far away from the tertiary center, then access to it becomes difficult. We have access to the slow release patches, and again, starting at a low dose, depending on all the factors of the patient. I always say you've got to look at your patient. If it's an old, frail lady, you're going to obviously start lower dosages versus a person who's been using heroin at home. You're obviously going to start higher dosages. So I'm very reluctant to say start on this dose. I think you need to firstly review and look at your patient. But always, in an opioid-naive patient, start as low as you can.
So the other thing also with conservative kidney management is what you're really thinking about is what quality of life you want your patients to have. And sometimes you have to think about what is more important, for the patient to be pain-free or for the patient to or for you to prolong the patient's life. For example, in the case of using NSAIDs. So it's every day it's a battle of choosing what is more important, longer life or better life.
Jane, there's something I think that needs to be mentioned very carefully, is that if dialysis is not a cure, so even if the patient is going on dialysis, this patient is actually still palliative. The only sort of kind of treatment there is an organ transplant. And I think it's very important to realize that good end-of-life care supports organ transplant. Therefore, looking at palliative care and the integration of palliative care across various sectors, not just renal failure, not just cancer care, not just cardiac failure or dementia care, but across everything, and having a palliative care mindset in hospitals also then increases your organ donation rates and ultimately your treatment of patients with kidney failure. So nephrologists should be starting to really advocate for palliative care in their discipline, but also across the hospital, because ultimately this will improve the real treatment of kidney failure.
So we had just yesterday, I think we had a review of medical students having their end of rotation review. And we were talking about renal supported care, and we were talking about, and they were saying that when patients don't do dialysis, it feels like there's nothing you're going to do for the patient. You're going to discharge them and they're going to go home. But then I was just highlighting the fact that when you do renal supportive care for the patient or conservative kidney management, you're not doing nothing. You're actually doing something for the patient. When people think about kidney failure, they think about either the patient's going to get dialysis or the patient's going to get kidney transplant, which doesn't happen for everyone. So being able to assess symptoms and manage symptoms and talk to the patient and walk them through their end of life, if they're going to be able to get dialysis or get transplant, is, I think, a lot that you're doing for the patient, and it's not really nothing. So just having that discussion with the patient is sometimes good enough, and the patient is happy that you've been able to show them that we are going to keep you as pain-free as possible. And this is why pain is one of the really important symptoms that you need to make sure you assess properly and treat properly for as long as possible.
Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts.